First of all, the left ear canal entrance was collapsed. It was completely shut. So the outer part of the ear canal, the outer third, is made up of cartilage. And just like our nose, over the years, this cartilage can weaken and at the tip it can droop. So in the case of your nose, that your nasal tip can droop, so it's called nasal droop. And that's just because the cartilage weakens and gravity has its toll, and cartilage can just, the nose can drop a bit. And similarly with the ear, so the cartilage near the entrance can kind of collapse upon itself. And the challenge then is to extract this earwax because the ear is shut. So we have to get a suction probe in, obviously we get an endoscope in. However, once you've got the skill and the technique, and I had a clear wax training course today, so I was teaching my delegates how to actually do this. And essentially what we do, fortunately the cartilaginous portion of the ear canal is flexible, so we retract the pinna, so the satellite dish, you bring it back and up, which widens and opens up the ear canal and straightens it, which then allows me to insert the endoscope into the ear. And we use the endoscope almost like a doorstop then, so we open up the ear, insert the endoscope. Not only does that provide us with the view, but it keeps the ear open, which then allows me to insert the suction probe in. So it is a bit of a technique. I'm sure the delegates today kind of realise that, and also past delegates. But once you've acquired that skill, there's no ear that you can't access with an endoscope, and that's why an endoscope is so good. So that's the first challenge, entering the ear. Now, the second challenge is the consistency of this wax and skin. More medially, so the lateral part near the entrance, I've already removed that. More medially towards the eardrum, this plug of wax and skin, it's a lot firmer. It's quite a few skin adhesions. It's really adhered to the canal wall. Now, the patient has also got quite a bendy ear as well. So most people's ears are bendy. It's like an S shape. However, I would say this patient's ear canal is more like a chicane. The bends are quite prominent. And you can see there's a few cilia hairs at the entrance as well. So we're probably about 2/3 in now. And you can see at the base of the ear canal, we've got these skin adhesions. So what we need to do is remove this plug, detach it from the skin. Otherwise, the skin's going to hold on to this plug of wax and keratin, and it's not going to allow me to extract it. So I'm just trying to wriggle it up. And once we've finished the procedure, you'll see the patient's ear anatomy. So this ear canal, most people's ear canals, if not everyone's, well, adults anyway, the ear canal, as you go into the ear, it goes upwards. So you've got an upwards incline, around 30 degrees. And I'll say this patient's is a bit more pronounced than 30 degrees. And then the patient has a sudden drop near the eardrum where the inferior recess in. So it is like a mountain slope. You're going up and then back down again. And when you've got a narrow ear like this and twisty ear, you have less room for manoeuvrability. However, again, with an endoscope, because we're not using a speculum, so typically if you have your ears cleaned via microsuction, a speculum, which is like a black funnel, so it's wide on one end, narrows on the other end, that's like a cone really. That's the tip of the cone is inserted into the ear, and the diameter that's around 4, 5 to 6 mil maximum. It depends, you get various sizes, and then the suction probe is placed through the speculum. And I can understand why some people use that, because if they find it difficult to manipulate an endoscope, I can totally understand it's going to help them. But that just narrows the ear even further, in my opinion. So if you have got the skill to use an endoscope to remove wax, because even in a narrow ear, you can see everything. It doesn't restrict the space. And that, again, you can see here. So although the patient's got a narrow ear, we have got access to the whole plug of keratin wax. And I'm slowly just trying to bring this forwards. It was almost stone-like, the consistency of this last piece, which is quite deep in the ear. Because I'm just wriggling it, just trying to mobilise it. You can see how much difference it makes when we stretch the ear open. It really does make a difference. It really widens the ear canal. And when you get a plug of wax or keratin, which is like this, we're just going to be careful, because sometimes it is difficult to achieve a suction grip because the surface is quite rough, and you place the suction probe onto the surface of this. Instead of suctioning it, you're inadvertently pushing it further in. So it's when you're doing the procedure, you get this kinesthetic feel. You can't explain it any other way. When you're in there, you can't actually see it, but when you're in there, you know, I'm going to be careful here because I'm not actually suctioning. It's not suctioning. I haven't got a suction grip. In fact, I'm pushing it further in. So I'm just using an ear hook just to see if I could have gotten behind this, but I couldn't. It was just too far in, and there wasn't much of an opening there. So I've just dosed it a bit more with some olive oil spray. And again, I've stretched this ear wide open. I'm now inserting the suction probe. And I'm just trying to lift it off the base and off the anterior canal wall. So this is the front part of the ear. And I'm just hovering at the surface and just hoping to achieve a suction grip almost without touching the wax. So if you just, sometimes you place the tip of the suction probe just near the surface, and without even having to touch the surface, you get this suction grip, and you slowly bring the sucker back out. You have to do it really, really slowly when you bring the sucker out. If you do it too fast, you lose that suction grip. So that's key. So when we train our clear wax delegates, we have to kind of educate them as well that you do have to, so when you get a suction grip, you hear the noise change, it changes. So it's all the senses. It's not only the feel of the suction tip against the wax or just in front of the wax, but it's the noise change. When you get a suction grip, the noise of the sucker goes down, and you have to kind of be experienced to know when and understand the changes of noise, what it means, and then slowly bring it out. Now, if you just get a suction grip and you just bring the sucker straight out of the ear, you're hoping the wax is going to come with it. Probably not, unless it's a crumbly pellet type of wax. Generally, most wax, you have to manoeuvre it out, and if you come out too quickly with the suction tip, you lose that suction grip. So just making little gentle wriggles. Now the patient's aware that they should have come a lot sooner. They've left this way too late. So we got a big plug out there. So that piece of wax just detached itself from the main body of wax and dead skin. It's not only so. What's the difference between wax and skin now? 60% of it in most type of earwax anyway is made up of dead skin. So you could argue there's not much difference, but when it's 100% or 90% or higher composition than 60% of keratin, you call it more of a skin plug as opposed to a wax plug. So wax is made up of a combination of 60% dead skin, and the remaining 40% is an oily lipid, fatty secretion called sebum, secreted by the sebaceous glands. These are the glands, same glands we get on our scalp, on the hair follicles. So they produce a kind of a fatty oil. And also it's a combination of a sweaty oil, modified sweat glands are inside the ear, attached to the hair follicles. We call them alpocrine glands, and they're the same sweat glands found under your armpits. And these glands, they don't produce a more of a salty water sweat like we have on our brow and our forehead, but this is more of an oily sweat. And when this oily sweat dries and evaporates and oxidizes, it gives off a foul odour. That's why sometimes earwax can be quite smelly. It can be quite a rancid smell, quite acidic. So yes, they're 60% dead skin. They're only 40% a combination of sebum and an oily sweat. Now, when it's just a keratin plug, it's going to be a much more high composition of skin. It would probably be 80 to 90% dead skin. Sometimes it can be 100% just skin. So this skin that lines the ear canal and the outer layer of the eardrum as it dies and sheds should naturally come out of the ear in a conveyor belt motion. But in some people, this conveyor belt motion is halted, it's stopped, it's prohibited for whatever reason, and you get a build-up of skin in the ear. The skin doesn't come out naturally. So we're just at the entrance here. You can see it just really, really narrow. This plug of dead skin, it's much wider than the entrance, the diameter of the ear canal entrance. So we just got to persevere. I think I'm going to use an ear hook in a moment because I brought this forwards now. I'm able to safely insert an ear hook. I was just obviously training the delegates today, and one of the things I advise is to avoid using an ear hook or a Jobson horn on the bony part of the ear canal. Because typically with an ear hook and Jobson horn, you're going to have to glide in behind the wax or the skin plug. And that means if the skin plug or earwax is in the inner 2/3 of the ear canal, the bony part, you're going to make contact with the bony part of the ear canal, which is going to be very sensitive. On the more cartilaginous portion where we are now, it's fine. We can make a bit of contact, apply a bit of pressure against the cartilage. It's not going to be uncomfortable for the patient. So unless there's an opening and the wax is deep, then you're trying to avoid it because you don't want to make it uncomfortable for the patient. Again, dissected a bit of hard wax, keratin out of the ear, gone back in with the suction probe. You can see I'm just wriggling this through. And because it's narrow, it's snapped in half, it's dissected itself. And sometimes it's slowly but surely. You just have to be patient, gentle. Remember, the patients are awake, guys, as well. That's one thing that you have to bear in mind. A lot of the patients attend with earaches. One of the symptoms of their impaction is earache, and so they're already coming to you with pain in the ear, and naturally when you go in the ear, you're not at first, until the wax is out, you could be adding to that pain because you're poking and prodding in the ear. So the ear canal's clear. You've got this dead keratin at the base of the ear canal, as you can see, the white dead skin. So using a fine end gauge just to clear this up. You can see the ear is very, very bendy. It really does veer off to the left. You can see the inclination of the ear canal, what I referred to before. So most people's ears do incline, but I would say this patient's ear canal inclines more than the norm. And at the summit, it then dips back down again near the eardrum, and that creates an inferior recess at the bottom, which we can actually visualise with an endoscope. So that's the patient's left ear done. This is the same patient now. You can see the consistency now is completely different. You could argue this, it looks like wax, but actually it's probably wax, but more with the more higher concentration, composition of dead skin, sort of 60%, about 70%. And I know that just through experience, but I can tell by the colour, the texture, it's quite reflective. So all these, when you've got more of an orangey colour, and it's reflective, and it's sometimes glutinous, it's actually dead skin. There's a high concentration of dead skin. Because it was a bit glutinous, the consistency, straight away I put some olive oil spray in just to change the consistency. It kind of binds this wax together, so it just makes it easier to suction. And when it's a bit glutinous and wet and mushy like this, it can quite easily block the suction tips. And oil is obviously a natural lubricant. It just lubricates not only the suction tube, the inner part, so the wax can travel up the tube, but it also lubricates the ear canal wall, but it's still very mushy. This is, for me, obviously I really enjoy removing wax, very satisfying, rewarding, but this type of wax is probably the most frustrating for me, is it keeps blocking the suction probe, so I have to get in and out. I think I'm going to use some more drops again, if I'm correct. We shall see. So compared to the left ear, so the right ear canal entrance it wasn't shut, it was open, so you still expect some natural migration of this skin to come out the ear naturally, somewhat, but I suspect, so it is still narrow, but it's not as narrow as the other side, so just put some oil in. But I suspect because of the consistency of this, because it's sticky, as the wax is migrating out, it's sticking to the canal wall. And we're just going to be really careful, because the wax is a very similar colour, it almost camouflages the canal wall. It's hard to distinguish where the canal wall is and the wax, so when we're removing wax off the canal wall, we're just going to be careful that we don't overcompensate and then dig into the canal wall, and we just remove the wax, we make contact with the wax and nothing else. So again here, it's just very hard to gauge how thick this layer of skin is that's coating the canal wall, and we don't want to then compensate and graze the canal wall because we think it's because it's a lot thinner than we believed. Now again, we're explaining to the clear wax delegates today, at this stage, technically speaking, the procedure is fine. We can halt it here because the patient's symptoms would have been alleviated, the blockage is clear, we can see the eardrum, but I'm just trying to gently remove as much of this dead skin off the posterior and inferior canal wall, and we just do that by again, we're in the bony part of the ear canal now, so we've got to be really, really careful. There's a couple of hair strands that I extract as well using forceps in a moment. So hopefully there's quite a few good tips for, so a lot of the clear wax trainees that we train to do, I do encourage them to watch. It's just because when we try to remove earwax, there's so many different types of earwax, and it's kind of near impossible to teach every single type of earwax and every type of ear anatomy. There's so many permutations, variables, and I just encourage them to watch the videos and learn and see how I approach different types of wax. Now in this ear, it's obviously still got an inclined ear canal somewhat, but it's not as pronounced as the left. But some oil, not only from today, but patients have obviously been using some drops before, it's got trapped in the inferior recess. You'll see a little puddle of oil in a minute, and I'm actually going to suction it out and you'll see that. So before we do that, we're just mopping up the posterior canal wall, just using a fine end gauge here, or a fine suction tip. You can see there's a few hairs that are matted against with the skin and wax. I'm just gently hovering over without trying to make contact. So we just stretch the ear open, keep it open with the endoscope, and then we're going to go in with the suction probe in a minute. And just at the bottom there's a little puddle, you'll see it in a moment, a bit clearer as we get closer. You can just see here, this is the inferior recess, so there's near the eardrum where the ear canal narrows and widens, it creates a trench, a basin, not only at the bottom, you can see the little bubbles there of drops, we'll just clear that up. But also on the right-hand side, the anterior recess is a little cave there, hidden trench. Quite often you can get water, so sometimes when you get water in your ear and you're trying to wriggle it out, it gets trapped